morning, everyone. I know you've been waiting at the top. It's a little bit after the top of the hour, and I am Lisa Gall. I'm a nurse practitioner and a quality improvement advisor for Superior Health Quality Alliance. I have our team here, Christine Lamb, Carrie Finley, Janelle Shear, and Barb Link. And we welcome you to this session. We will be covering a little bit of discussion about the home health value-based payment improvement in dyspnea measure. And so we'll be covering a little bit of that today, and then we'll have some time for some questions and answers at the end. However, if you do feel like you have a question that you want to put into chat, we'll be monitoring the chat as well. You want to show the next slide, please? Okay, this meeting is being recorded just for everyone's information. We will, if you have something that you don't want to say under recording, you can go ahead and put it in chat. Those will not be in the recording. So our home health aid work group goal for this year is the meeting monthly to provide opportunities to connect with other home health agencies across Minnesota, Michigan, and Wisconsin. And we share ideas, current information, and best practices. We do some discover and discuss strategies to help your agency provide the best care for your patients. Next slide. So we'd like you to enter into chat at this time as you're joining us, your name, your title, the organization you work with, and which state you are in. And also just a fun little fact, what is your favorite summer treat? We have some ideas up there, but you can use your own summer treat. And we try to keep this fun and interactive, so we want your participation as much as possible. So go ahead and enter that into the chat at this time. Okay, we have some, obviously Carrie, Blue Moon ice cream. Mary Eating from Michigan, Atrio Home Health, popsicles. Well, those are the lowest calorie treat I can think of for the summer, so I should probably move over to those. Barb, our QIA lead from Michigan, Turtle Sundae. I love ice cream of any kind. Christine Lamb from Superior Health. She loves watermelon, preferably seedless. You don't have to spit them out at anybody. I like the seeds so I can spit them at people. Janelle, Quality Improvement Advisor in Minnesota, Dairy Queen Hot Fudge Sundae with peanuts. Oh, yeah. Keith, My Michigan Home Care in Michigan, fresh fruits and vegetables from farmers markets. Oh, I love you healthy people. I was going for the calories. Okay, let's move on to the next slide. As people come in, they can add their information. And the sessions and agendas for this year, we have talked in session 1 and 2 about the home health value-based payment program, overview, the functional score, and today we'll talk about the improvement in dyspnea measure for that particular item. Next slide. In future meetings, we will, at the next meeting in June, be covering improvement in management of oral medications. And then the last meeting that we have scheduled at this time, best practices in care transitions. Those are our future topics. Next slide, please. So we're going to be covering today the documenting improvement in dyspnea. This is an OASIS measure, and it's captured by completing the OASIS, and you get a measure score based on the HHVBP. Of course, through your quality reporting and reimbursement. And we're going to show you some interventions to improve dyspnea in home health patients and how that impacts your score. Next slide. I think this might be a repeat. It's just a little bit of a detail on the discharge function score, what we covered in the past. The discharge function score is also an OASIS assessment. Uses data from the OASIS assessment. It considers both self-care and mobility activities. If you do and did miss that session, it is available on YouTube. And I don't know if one of our partners can find out where that YouTube is and perhaps put it into the chat for the past discharge function score. And then today we'll be covering the dyspnea, how it's scored, and then next one will be improvement in management of oral medications. Those are the 3 home health value-based payment changes in 2025, and that's why we are covering them in a little more detail. So this year, 2024, you're going to be practicing them. Next year, you will be actually scored on them. Next slide. This is an overview of the home health value-based payment reporting, the weighted scores, and the use of data. And I see that Christine said that the YouTube has not yet been posted, so we'll let you know when it's available. So the weighted scores, there are 3 OASIS-based measures on the left column, improvement in dyspnea, discharge, improvement in management of oral medications. And then in the past, there were some OASIS-based measures, discharge to community, and the total normalized composite change in self-care. Those will be going away, and we'll only have 3 OASIS-based measures. And those are the 3 we talked about. They will be weighted for the score for home health value-based purchasing at 35%. Unless you only have 2 measures, then it's weighted at 50%. Each measure, each group of measures. The claims-based scores are acute care hospitalization and emergency department use without hospitalization. And those again will be weighted, that composite score will be weighted at 35%. Unless there are only 2 measure groups to report from, then it would be 50%. The last one is your HHCAPS, your home health consumer assessment of health provider survey. That has 5 questions in it. That's your surveys from your consumers. And that again is weighted at about 30%, unless there are not enough surveys for your agency, and then the other 2 weights are weighted at 50%. And then you can see on the columns on the right hand that it's not only for the HHVBP that some of these measures are, but the quality of patient care star ratings are impacted, as are the patient survey star ratings and care compare. So a lot of these are very visible to the public eye. So it's very important that you have good ratings in there so that you are visible. You can show off your good work. Next slide, please. So in covering the improvement in dyspnea OASIS question, which is M1400 in the OASIS, the numerator, the denominator, exclusions, and OASIS C2 items that you will use. So the numerator is the number of home health quality episodes where the discharge assessment indicates less dyspnea at discharge than at start of care or resumption of care. The denominator is the total number of home health episodes ending with a discharge during the reporting period, other than those covered by generic or measure-specific exclusions. And those exclusions are for when the patient was not really short of breath at all at any time, or an episode that ends with the inpatient facility transfer or death. So those are excluded. And then the OASIS C2 items is when is the patient dyspneic. The OASIS measure is linked in the bottom. This measure specifications, much more detail in the bottom of this slide and at the end of the slides. Next slide.
That looks like there's a question, but it looks like it's a question more for the group. So I don't know where you'd like to.
Oh, yeah, let's look at that. So
Okay.
maybe you'll get into this a little later, what people are doing to improve their dyspnea scores and clinician accuracy. I have the what to do to improve dyspnea scores. We'll go over that. And then accuracy, we can do some discussion on that, I think. Thanks, Barb.
That was from Karen.
Thank you. And thanks, Karen.
Okay.
So the OASIS guidance is, this has been taken from a webinar that was put out by CMS, and they did cover the OASIS measurements. So 0 is the patient is not short of breath. 1 is when the patient is walking more than 20 feet and climbing stairs before getting short of breath. 2 is with moderate exertion, like when they're dressing, using a commode or bedpan, or walking less than 20 feet. A 3 is with minimal exertion, like when they're eating, talking, or performing other activities of daily living, or if they're agitated and get short of breath. And 4 is shortness of breath at rest during the day or night. So that's the scoring. And what you do need to do is to improve accuracy for your clinicians is to report what is true on the day of the assessment. And that includes 24 hours immediately before your home visit, and as noticed by the nurse, by the clinician while you're in the home. So it's a partial reporting and partial of what's observed. And you're going to have to make a clinical judgment on that, you know, if you're not noticing the patient is short of breath, but they're reporting that they walked to the bathroom and they got very short of breath, that you do need to take that into consideration. And then there are some examples in the reference that you can look at as well. Next slide, please. So oxygen use, if the patient uses oxygen continuously, you should assess them with oxygen. If they're using it intermittently, you should assess them without oxygen. The assessment is based on the patient's use of oxygen, not the provider's order. And then if the patient's environment is modified to address dyspnea, if you see that there are, or the patient is reporting that they're sleeping with 2 or 3 pillows, or they're sleeping in a recliner, that's obviously a sign of being dyspneic. If the patient has not demonstrated or reported some shortness of breath during the day of assessment timeframe, select 0. Even though the environment or patient activities were modified in order to avoid shortness of breath. So if they have modified it and they're not getting short of breath based on their modifying the environment, it's a 0. Next slide. And the improvement achieved is a rating at the next point of time, and maybe it's at discharge. So that initial scoring was that first day, and now you're doing the improvement achieved. And so you have an improvement shown if your discharge oasis score is lower when compared to your start of care or resumption of care score. So if you started at 2 and now they're at 1, that's an improvement. So that counts towards your final score that, yes, you had an improvement. Next slide, please. And then how do you, as a clinician, deal with and implement measures to address and improve the dyspnea? First, you want to establish a goal with the patient. What is realistic for them? You know, of course, you have your SMART goals. You know, it's measurable. SMART, S. What's S for?
Specific?
It's what?
Is it specific?
Specific, yes. Okay, sorry about you guys. I just had a brain block there. Specific, measurable, achievable, realistic, and a time frame. So do a SMART goal with your patient. Get the goals. What is their goal? What do you feel is realistic? And then establish an emergency action plan. We're going to show you some stoplight tools that are going to be very helpful for you to use for not only your clinicians and your, you know, frontline staff, like your home health aides, but also your patients and their families and caregivers. So those stoplight tools are going to be very valuable for you on what the patient does when they experience some dyspnea. Also, the emergency action plan should establish some parameters for what if they do have access to a pulse oximeter, what is their normal? And, you know, so you might need to know what is their normal now for pulse oximeter, what have they been doing in the past? And if they don't have a pulse oximeter at home, then you may not need to establish those pulse oximeter parameters. So do the goals based on what you have access to for your patients. Hopefully they do have pulse oximeters. And then educate. You're going to be teaching your patients some breathing techniques, some relaxation techniques, you know, the pursed lip breathing, all the things that, you know, nurses and therapists have been taught to, you know, help patients deal with shortness of breath. Of course, energy conservation, so that they're not, you know, going out and cutting down some limbs in the trees or raking and then, you know, very short of breath, you know, so obviously they're not able to withstand some of that level of activity, but energy conservation in little bits and pieces of time so that they can manage and still do the things that they want to or need to do. Making dinner, for example, might need to be in steps rather than all in one standing or sitting. And then, of course, notifying, informing your patient what to watch for infection, signs and symptoms. If they're feeling, you know, chilled, feverish, you know, make sure they have a thermometer, all the things available to them so they can identify early whether they have a true infection, respiratory infection. And then making sure that they are up to date on their immunizations and other preventive cares, drinking lots of water to thin the secretions, using mucolytic medications to thin the secretions also, like Mucinex. And then make sure that they have advanced care planning on file. And so that their families and you all know, you know, what their wishes are if they were to stop breathing. Next slide. The second part is to identify and mitigate any contributing factors. So this is a process, you know, it's kind of like your PDSA process, you know, you're going to, you know, plan, you're going to do, study, and act. But really what you want to first do is assess many things. And when you're doing your OASIS assessment or your home care intake assessment, you want to find out if they have anxiety or depression. Both of them can interfere with breathing. Of course, anxiety is going to increase their respiratory rate. Depression may decrease their respiratory rate. And, make sure that you have appropriate, for each of these, it's an assessment, an educate, a teach back, referral, or consultation, and then reassessment. So this is basically the nursing process for every one of these areas. So first the mood disorders, then the oxygen. Do they use it? Do they need it? Do you have orders for it? Is their order appropriate for what they're doing with their oxygen? Really let their provider and their clinicians in the clinic know what's happening in the home. So, and medications related to dyspnea. What medications do they have? Do they have NABs, inhalers? Do they use diuretics? Are they using their diuretics and their NABs and inhalers as ordered or as needed? They may not think they need to use them, but it may be ordered regularly. Usually NABs are not, unless they are sustaining a preventive nebulizer or inhaler. And then environmental issues. What kind of heat are they using? Do they have air conditioning? Is the weather impacting their breathing? Is it the middle of summer in August and it's so humid they can't breathe? Is it that environment thing? Do they have allergies? Spring and fall allergens, right now the lilacs are blooming. Is that causing, is it the ragweed in the fall that's causing their shortness of breath? Are they exposed to smoke or dust? Obviously, you're visiting them in their home. You can see whether they are, keeping their home as dust-free as possible. Most elderly don't dust on a normal basis because especially if they are short of breath. But removing that dust can make a huge difference. Just vacuuming can make a big difference in their shortness of breath. So if they can get housekeeping, homemaking services to clean their environment and make sure that they're not breathing in all these even animal dander, cats and dogs. You can't get rid of their cats and dogs. They want those. They love them. But you can certainly, make sure that it's as dust-free or as hair-free as possible in the environment they are immediately in, especially their sleeping environment. Amazing what vacuuming under the bed can do for people's breathing problems. Also making sure they know, assessing whether they have an upper respiratory infection or other signs and symptoms of infection, so that you are, treating early, referring and treating early, and, assessing their activity intolerance. What is it that makes them short of breath? Why are they short of breath? Is it how they're doing it, how much they're doing? So again, it's just assessing, educate, teaching, making sure they're understanding, doing the teach back, ask them to repeat what you just told them in a different way. What did I just tell you about this? And then referring, consulting, and then reevaluating. So there's a lot of things that go into the breathing measure and things that you can use to intervene and provide appropriate interventions. Next slide. So here are 2 self-management plans that you can use during your home visits and to leave with your patients in their homes. And if you, these are not very visible on the page here. The links are included right below them, and Barb has just added them on to the chat. They're the asthma tool and the COPD self-management plan. The nice thing about these tools is that they are available in other languages on the websites. So this COPD self-management tool is available in several languages. So the green zone, I'm just going to talk about the green zone. Thank you, Christine, for flipping that next slide on. It tells that, okay, if I'm breathing easily without shortness of breath, I'm not wheezing, I'm not experiencing chest tightness, I don't need to decrease my activity level in order to maintain my breathing. The yellow zone, I'm just giving a few examples. You have an increased cough and sputum in cough, sputum, and symptoms, increase in shortness of breath, need for more quick relief medications like their albuterol inhaler, perhaps they're using more often. They're need more pillows to sleep. Their ankles are more swollen. You have chest tightness. And what should they do? On the right-hand side, it's what do they do then? So they can continue, taking daily medications. They can use oxygen if prescribed. And then they should contact their physician, nurse, or home health nurse to discuss their change in symptoms and possible adjustment of medication. We don't want them going just to the ER when they have some of these yellow caution zone symptoms. We want them to contact someone. You guys are the first line. You're there in your home, in their home. You can see what's going on. Maybe that first line is going to be the home health agency. And so you want your number on this part so that they can contact you when they look at this. If you have a sticker, you can put it across the top there, but I would put it in the yellow area. And then, of course, their physician's number there, or their clinician, they're seeing a nurse practitioner or PA, their provider's number and their phone number as well. And then on the third part of this, it is the red zone. They have unrelieved shortness of breath, chest pain, or chest tightness. They have shortness of breath, wheezing, or tightness at a rest state, increased or irregular heartbeat, fever, shaking, chills, need to sleep sitting up in a chair, changes in the color of their skin, nail beds, lips are gray or blue, and experiencing confusion or coughing up blood. And this is more of the red zone emergency. They should go to the emergency room or call 911 immediately. Of course, this is going to vary by patient. You know, some patients are extremely short of breath all of the time. So you will need to know your patient's normal and emergency plan and work through that with them so they know what's the point when I go to ER. So the next slide, please. The asthma one is very similar. So, you know, that we just showed you as an example, the COPD one. Okay, hang on here. I gotta just read. Okay. So then, now that you've given them the tools, they have an emergency action plan, and you know what their plan is. They know what their plan is. Their caregivers know what their plan is for if they run into problem. So then we're going into the home-based pulmonary rehab action plan. So this is more on how do we get them better overall. You know, sometimes shortness of breath is basically only a, I shouldn't say only, but significantly contributes to shortness of breath is deconditioning. So you want to recondition your patient. You know, set a goal for their walking distance, have them use it if they have a pedometer, and maybe their goal is 30 minutes 5 times a week. This may be way out of their comfort zone or ability, so you got to work with the patient on what their goal is. And they should record a completion in a home diary, so help them set up a diary that they can write down their walking and exercise. Of course, then besides aerobic and walking, it's upper and lower limb strengthening, like stair training, sitting to standing from the chair, And then some free weight training. I mean, there's a lot of free weights out there, cans of soup and whatever, rubber bands, the stretch bands, any of that can keep their functioning in their limbs. And then on the right side, the patients should be following up with their clinician on a regular basis so that the clinician can review the home diary, progress the exercise prescription, deliver disease-specific management and or training, and then explore and build motivation for change and move towards commitment and action. All of this is not just their clinician in the clinic, but it's the clinician visiting their home. So we want a very specific plan. You want a very specific plan. Are you going to visit them weekly? Are you going to visit them 2 or 3 times a week the first week or two? Start strong and then go down so that you have a period of time. Usually those care plans are, if I remember right, they're a 2-month period. So figure out your plan and, start strong, taper down, and, start hitting some of those things early on so that your patient has some time to recondition and to do some pulmonary rehab at home. And then, of course, during that time, building motivation and, just keep giving them encouragement. And they may not see the progress that they are making, but you will have a better eye on how they're doing it because you're seeing them intermittently and you can see some of the progress. So just encourage them and keep them motivated. Next slide. Okay, so this is our discussion time. We want to know kind of what are your current strategies for managing patients with dyspnea? Is this kind of fitting what you're doing now? Is there things that you have an idea that you might want to take to improve your current strategies? So I guess we'll start with a question. What are your current strategies for managing dyspnea? Can we open it up for discussion? And if you don't have current strategies, what steps might you take to implement strategies to managing patients with dyspnea? So we have Karen, Mary, and Kay going, as far as participants. And, I guess if we could go round table just to see what each of your organizations are doing, we'd really appreciate your feedback on this.
This is Kay. So I know that the QI nurses do education on specific items. I know that they are working on
This
this.
is Karen. We have a level 2 clinician that works with.
Oh, Karen, I'm going to have Case go first here, please. And she started, sorry.
Okay, and so then we also use, I'm sorry, I'm getting texted from work at the same time as I'm trying to talk. We also use our, the data they get, where they collect the data from the Oasis and blah, blah, blah. They use that, that information to do one-on-ones with nurses. You know what I mean? So that they can see that the way their starts of care and maybe their discharges, there's no change. And so they do one-on-ones with them to see, was there really not a change? How are you looking at this? How did you score? So it's all about education, right? Sometimes individually and always as a group. So everybody's hearing the same thing at the same time. So that's what they do.
When you say group, what do you mean by a group? Is it your clinical group?
Yes. The people who are the nurses and therapists who are completing the Oasis.
Okay.
The start of care and the discharge, right?
Yes. So how about tools? Are you using any tools or strategies to, other than team collaboration on a score?
Well, they are using the tools. They're using the vendor that they get that collects our data, that pulls our data. So they use that to see how the clinicians are answering at both at start of care and at discharge. And and they use the data they get from their the HCAPs and the tool that pulls all that information. We're able to see what clinicians are scored high, what clinicians are scored low, and then again, it's a one-on-one to see if there's some issues or misunderstandings, because everybody wants to do the right thing, right? And even though we are presenting at the same time, so they're all hearing the same words, people hear things differently. And sometimes when they have those one-on-ones, then they discover that the way they interpreted something was not the intent.
Got it. Thank you, Kay.
Mm-hmm.
Karen, you want to be next? Karen, you're on mute.
Sure. We've contracted out our coding of our OASIS, and that has helped some to make some improvements. That company.
Okay, you broke out there for a little bit. Are you back?
Are you able to hear me now?
Yeah, yes.
I've unmuted.
Okay, now I can.
Are you able to hear me now? I'm unmuted.
We can hear you. It seems to be a
Okay.
little hit and miss. Just
We
go
have
ahead.
a company that we contracted to review and code the OASIS, and they give feedback to clinicians if the documentation isn't lining up and isn't accurate, or how about if I type it in the chat?
Yeah,
That sounds good. Yeah, there seems to be a little connection problem. So that
because
would
we
be
hear you for a
helpful.
while and then it's like silent. So I don't know what's going on, why that happened, Karen, I mean. And then in the meantime, is it Mary? Mary, are you able to talk in?
Sure. Can you hear me?
Yes.
Okay. Um, so we use like the teaching, a lot of the things that you mentioned, what Kay mentioned are all things that we also do. So we use the stoplight tools, we use team collaboration to help instruct them for better scoring. But I do plan to bring back some of the things that you mentioned to our staff to maybe, expand on some education issues and revisit, because dyspnea is a measure that we struggle with meeting that benchmark every quarter. It's always been a bit of a struggle for us, even though sometimes it seems like we're getting closer. But then, we just never quite meet it. But one of the things that I have been thinking is that we don't really do a great job care planning in regards to that. I feel like that is something we could work on better. Like our staff, we go to see patients for a specific reason, like maybe wound care. And then on the OASIS, they may have some dyspnea, and they may score higher on it. And my thought is that we really need to just incorporate that into our care plans So even though our focus may not be wound, it may be something else like wound care or therapy or whatever, they still need to address it in the care plans. And I think that is something that we might not be doing so great on.
That's a really great point, Mary. And I'm thinking a wound care, lower extremity wound, they're not walking as much, so they're deconditioned, a little short of breath when they do things. And that reconditioning might be and that pulmonary rehab might be a good way for you to get that dyspnea score to move up for patients who are not seen for primary reason of respiratory.
Right. Yes, and I'm thinking that our staff aren't doing that. So maybe our QA team might need to, add that in as a care plan for them, or, talk them through with it afterwards whenever anybody scores higher. But yeah, those are definitely very good points.
All right, great. Thank you for your feedback. And then Karen has documented written in chat, contracted OASIS review and coding. They give staff guidance. We use level 2 clinician to offer staff education when they don't score low enough at start of care. We have an RN who reviews some of our outcome fallouts to see if a patient did not improve. Was it a documentation issue? We also use some disease-specific stoplight tools. So it's not, I'm glad you're all seem to be aware of the stoplight tools. And when I have a question for the for those who contract OASIS review and coding, is that a nurse or a therapist that goes in and does that who's not working for your agency then and visits the patient? I mean, either Karen or Kay.
I'm sorry, can you repeat the question?
And when you do your contracted OASIS review and coding, is that they're looking at the OASIS after it was documented by your nurse that did the visit, or who does the actual visit in the home?
No, it's our nurse. And then they review it to see if there are any contradictions. If they answered,
Okay,
yeah,
so they're reviewing the documentation.
correct.
Okay. And so you're still, it's your frontline staff, your nurse, your therapist, whoever's in the home doing that rating of the OASIS.
And it's interesting, it looks like Karen
Yes.
said they are not working for the agency for her organization. They are certified OASIS reviewer and coders, and they do it based on the documentation.
By
So it's
the
a little
home
different than
health
Kay.
nurse. Yeah.
And their home health nurse makes the visit. They have someone.
Okay. So it's reviewers of the OASIS documentation. And
Correct.
yeah. Okay. Any
Have you
other-
found that to be helpful to get consistency? Assuming it would be helpful, but
Yep, they find it helpful, yep.
yeah.
And it's a learning sometimes for the nurse too, or the therapist. Because sometimes, when they're reviewing it, like I said, they find contradictions. It's like, you said this here and you said that there, which is it? Pick one, whatever it is. They don't tell them what to pick. They just show, they review it and say, this doesn't make sense,
I could see when they're doing an evaluation of their activity, like for under the G codes for the activity and dressing, they may saying, oh, I'm short of breath when I'm getting dressed or taking a bath, but then they're not marking it in their dyspnea. That kind of contradiction is what I'm thinking is probably getting captured. Awesome. So the next question is, do you need any help from us, from one of our quality improvement, advisors, either for your leadership or staff, going over this tool anymore, or do you feel you have this? Because we're always here we're always here for help if you have specific questions. If we don't know them, we'll help you look where to find them. And I'm going to go to the next slide because there's a couple different slides here that I want to go over. Of course, we would like for you to post any resources that you have on our work group in Connect. And then any new action items and follow-up dates that are in there, we'll put into Connect also. So I hope we're getting into Connect because we do have posts in there. And then the next slide. Our next meeting date is Wednesday, June 26th. We'll be covering value-based purchasing, improvement in management of oral medications. A little deeper dive into that. And then the next slide, please. This slide represents a huge list of who to call for help. As I said, we are here for help, but really it's the Centers for Medicare and Medicaid Services help desks. All of the things that you may have questions regarding the home health value-based purchasing are addressed on this. The IQIES help desk, which is the second bullet in the bottom list, that is for OASIS type things. So in order to know which of these help desks or emails to call, I'm going to have you go to the next page, please. There is a help desk one pager that explains what each of those numbers do and who to call for which specific help. So this is a one-page guide to home health help desk, and it's available on the link below. I don't know if we're going to be able to copy that from here or not, but it is a nice one-pager guide on, oh, I have a question about, hey, HHCAPS. Who do I call? Or star ratings, or home health quality reporting. So each of these has specific numbers and different numbers. So these are your go-to people. And, really it is very important to know these numbers and to be in connection with them. It's not bad to have that life link to them for, let's say you get a low star rating one year. Well, that's out there for a year. So you really want to work on that for the next year. Maybe you want to be looking at your star ratings. Why are you getting such low star ratings? Is it because of your HCAPS? Is it because of your quality reporting or your, some other area? Next page, please. And of course, if you have questions, you can call us and we can help you. And then the final page, as we talked about, Connect is that shared learning environment for you to come together. And we'd like you to post any questions, even if it's regarding one of your really complicated questions. Maybe posting a question could, be helpful as well. So we just try to keep everything in Connect. And then the last page, please. These are our references for this session. And that concludes our session for today. Like I said, reach out to us if you have questions. Reach out to CMS if you have specific questions. If you're needing help with, large, major things, feel free to call us or email us and, or post on Connect. Do any of our other team members have any other comments or suggestions?
But it looked like Mary went off mute for just a second. I'm not sure.
I was just going to say thank you. I
Okay.
appreciate this very much to be able to join this and having the extra support and knowledge is really helpful.
Thank you, Mary. Thanks.
Great. Thanks, Mary. And you are very welcome yourself. So we love to help our home health agencies, and we're one of a few organizations across the U.S. that are working with home health agencies, and so we're very, very proud of our small little group here. And we love to have you, and we love to hear from you, and to find out how we can help you best.
I guess if I could just share quickly, I don't have anything to add other than we do have one of our other groups that we work with here at Superior Health has a health equity conversation series coming up. And if anybody's interested in that, share my screen.